Good afternoon to everybody. Thanks the chair for your presentation. My name is Francesco Trevisani. I am a clinician scientist and I work inside the urological team and department in Raffaele Hospital in Milan. I am also part of the board of the diabetes, and my conflict of interest is related to Biorec because I am the CEO of this new startup aimed to detect new biomarker in renal cancer. So, in my presentation today, I will explain you the relationship between a chronic kidney disease classification and renal histology. Well, I hope to explain. The aim of my presentation are related to main aspects. The first one is, are CKD classification in line with a real renal damage, and does renal histology match or not with CKD classification? Well, in 2015, Barack Obama launched the era of precision medicine, which was a cornerstone, a very important aspect of medicine in different fields, in order to create a new strategy which was able to detect a real tailored approach for each patient. And especially in some disciplines, for example, surgery. Consider the Da Vinci robot, which can operate better than a man and with a very great precision in different fields, especially in urology. And also a new target therapy related to cancer, new barrier and frontier radiology and radiogenomic. And so new approaches that are tailored to the patient and able to create some new therapy and new algorithm on clinical practice every day. But what about nephrologists, where we are very proud because we did a lot of things in these last 2 decades in therapy and clinical trial, and so we are able now to treat some diseases that once upon a time was impossible to discover and also to treat in an accurate way. But in my presentation I will speak about the classification because it is important, is a new very precision medicine idea that perhaps harbors some errors. Why? Well, moving back to the first time that nephrologists decide to create a new strategy to prevent patients from dialysis, in 1995, the National Kidney Foundation launched the Dialysis Outcome Quality Initiative, the DOQI, in order to stop patients to enter dialysis, which represented also a huge amount of money for national healthcare system. But then in the fall of 1999, the board of directors of the NKF approved a proposal to move on and to create a more comprehensive clinical approach able to embrace a different aspect of chronic kidney disease. So not only the end-stage renal 1, but also the first degree of renal damage. And in order to reflect this need and this idea, they create the KDOQI, so the Kidney Disease Outcome Quality Initiative, so changing the name of dialysis in disease, in order to comprehend a more broad approach for clinicians. And one of the main instruments used to create this classification was related to the GFR. Why GFR? Well, because the glomerular filtration rate was considered one of the best instruments that both clinicians and patient can understand better in a good way in order to stratify patient upon renal risk. And also because for a patient and a clinician, kidney is like filter, so the GFR is quite intuitive to understand how your kidney works and how your kidney feel. In the sentences, you know your number, because the nephrology is creating, using the GFR, a continuous scale of system from higher than 19, which means normal renal function, to less than 50, which means end-stage renal disease. And this continuous scale, we've created the new step of renal diseases, consider the aspect of renal damage in the patient. And this was the first graph comprehend the estimated GFR, the GFR, in order to stratify patient upon risk of CKD. But there are some issues related. For example, we can think about the ages because elder people can have a decreased GFR but without renal problem. And in 2012, the KDOQI changed its name and arrived the KDIGO guidelines with new idea and new strategy better than the previous one. And in this new graph, the KDIGO considered the GFR, which can be estimated or measured, and also the level of albuminuria. And so the intersection between GFR and albuminuria can help the clinician to understand the grade of renal damage which a patient can have or not. And as you can see in this map, we have some green lights related to patients without renal abnormalities, but with a GFR less than 19, which is the normality, suggesting that nephrologists understood that the patient also with an eGFR less than 90 but without renal abnormalities are normal and not CKD patient. On the other hand, when the patient display a level of GFR less than 60, becomes automatically a chronic kidney disease. So a new strategy, a new idea to stratify patient, with some important aspect that I would like to sum up in this slide. For example, the first evaluation of a patient. So to understand if a patient have or not chronic kidney disease, the clinician should start using a serum creatinine level and an estimated GFR equation, MDRD or CKD-AP, in order to give an initial assessment, in order to understand if a patient suffer or not from chronic kidney disease. And then we have the evaluation of albuminuria using with albumin excretion rate and serum creatinine excretion rate. And last, I will stress also one important aspect, especially for me and for my friends from diabetes group, that is suggesting a measured GFR use. Well, this is quite important because the use of measured GFR is not so frequent in clinical practice. However, is quite important, especially in some cases. Consider, for example, obese patient where the body surface area can dramatically change the aspect of GFR, or also in patients with different problems related to cachexia or also oncological problem. So the measured GFR should perform, and this is written in the KDIGO guidelines, every time then when we need a more accurate treatment of GFR, maybe to create a new surgical approach, maybe to tailor an appropriate therapy. So initial is the estimated GFR and albuminuria, but then if you want to be robust in the decision making of chronic kidney disease, we should have a measured GFR. Well, it seems all clear, but that's not. And as my friend Esteban Porrini always tell me, take care, Francesco, because the nephrologist is in the mist still now. But why we are looking in the mist? Well, I have reported some aspect and 4 small clinical cases I fit during these last 2 years. And we can have the first cases, well, female age 63 with a serum creatinine quite normal, 1.2 ml, with an estimated GFR very low, 39 ml, and also measured GFR, which is very similar to the estimated GFR. Why this case is important? Because 1.2 ml of serum creatinine is considered for a lot of clinicians normal without renal problem. Otherwise, however, this guy has a very important CKD. The second case, we have a young male, 39 years old, with a normal serum creatinine, and he performed the clearance of creatinine, which is very common in some field of medicine. And this clearance arrived at 200 and was repeated 3 times to confirm this aspect of hyperfiltration mechanism. And so we were a little bit afraid of. However, using a measured GFR with oxalol renal measurement, we found that the real renal function was 83 ml, so the MGFR in this case was fundamental. And then we have another one with 78 female with a high serum creatinine, 2.9, an estimated GFR of 15. This woman should perform a chemotherapy, and with this very low grade of estimated GFR near to end stage and to dialysis, well, out of every type of protocol. Fortunately, we performed the MGFR, and what we found was that the level was double, 29-30, and so this woman underwent chemotherapy and she's still alive. And then we have finally a radical nephrectomy man with an estimated and measured GFR using renal scintigraphy before surgical operation of 34, 36, and after the operation the measured GFR using UXOL was 37, so it's quite impossible that the baseline 2 kidney works 34, and then after 3 months with only 1 kidney 37. That means that probably we are in the mist because we are using not the correct measurement to detect the renal function. But in these 4 cases, the measurement of renal function using UXOL was fundamental and crucial to decide the clinical management. And then this is the first study we performed together with some guys of the diabetes. We decided to undergo a very huge group of patients, more than 1,300, who underwent radical nephrectomy or who underwent medical therapies for oncological purposes, who underwent living donation, transplant. So different field of onco-urological and nephrological patients in order to detect the discrepancy between estimated GFR and measured GFR, in order to understand if the estimated and so the formula GFR should be correct or not in this patient. And what we found was dramatically surprising. As a matter of fact, as we can see, this is a B-centric study performed in Milan and in Tenerife with Dr. Porrini, showed that there is more than 50% of patients that using an MGFR instead of AGFR show a huge discrepancy. As a matter of fact, we have 50% of patients with an AGFR different from 5 to 20 and more than 20 ml. That means that probably when we say that a person have an AGFR of, for example, 20 or 30, the measured GFR can be 5 up to 20 ml less or more, suggesting that we are speaking about nothing in some cases. And especially in this kind of patient, when we want to donate a kidney, it's quite fundamental to have the correct measurement. And so in these cases, the CKD classification fail to detect the real function of this patient. And if you fail in this case, you can dramatically affect the lifespan of this oncological and neurological patient or living donor. And what we found and what we decided to suggest at the end of this work, of this paper, was a new algorithm in order to increase the use of MGFR, especially in this particular field of patient. And our flowchart considered that if you have an estimated GFR less than 60 and you should go to radical nephrectomy or to chemotherapy with nephrotoxic effect or other type of surgical approach that can compromise the renal function, well, the measured GFR should be performed in each of these cases, because sometimes the MGFR can be similar to the estimated GFR, but sometimes not. And when it is not similar, we can have a completely different scenario for this patient. And also in cases when you have an AGFR higher than 60 ml, but you have some kidney abnormalities such as hyperfiltration, proteinuria, or maybe you should come to a type of surgical approach which can reduce the nephron mass. Well, even though you are normal renal function for the CKD classification, maybe a measured GFR should be performed to be more safe, to be more secure and optimistic also in the development of chronic kidney disease. Because if you understand now which CKD class you are, then we can establish a correct protocol and precise management. But we should looking beyond and not only between the war from estimated GFR and measured GFR. And what we decided to do was look inside the renal histology. Well, nephrectomized patient, I work in urological department, so it's quite easy for me to detect this type of patient. But nephrectomized patient for renal cancer represent an in vivo perfect model to compare estimated GFR formula to renal histology. So can the renal parenchyma predict GFR decline? Why I say this? Because normally, especially for normal renal function, it's impossible to have renal biopsies of this patient. And so it's impossible to understand what happened in the kidney in terms of renal abnormalities and histological modification. But in these cases, we have a lot of patients suffering from cancer that have no type of comorbidities, or on the other hand, initial stage of diabetes, initial state of hyperfiltration, and so glomerulosclerosis. And so using this type of cohort, we can discover a lot of things that normally are uncovered and not clear to the clinician. And what we did was to enroll in a retrospective phase more than 200 of patients who underwent a radical nephrectomy for renal cancer in my hospital, and then we compared the renal aspect to the estimated GFR of this patient in order to understand if the renal histology modification can be similar to the eGFR level and to the CKD classification. And what we did using two different pathologists was to take the healthy part of the removed kidney, so the removed kidney of cancer was considered, and then we take a part of the renal parenchyma far more than 3 or 4 centimeters from the tumor. Two pathologists review this histological feature in order to avoid pieces with a high grade of fibrosis related to cancer and also to avoid the presence of metastatic cells or renal cancer cell inside the pieces. And when we discriminate this group of patients, we choose the healthy part from the renal parenchyma inside this kidney, and we consider some huge slice of renal parenchyma, so like a pizza slice and not like a biopsy slice, because we have a lot of material, and so we can deeply investigate the renal modification, see a lot of glomerula, so more than 50 glomerula for each cases. We use a chronicity score when we consider both Remuzzi score and SETI score in order to create an idea to detect the presence of initial fibrosis or renal damage. The SETI score looks predominantly on 4 different aspects. The first is related to the glomerulosclerosis cortical aspect. Then we have the interstitial fibrosis. Then we have the tubular atrophy and arteriosclerosis. Except for arteriosclerosis, which has a score of 0, that means absence, and a score of 1, that means presence, all other parameters are scored. So, with the score of 0, it means less than 10% of initial fibrosis and tubular atrophy and glomerulosclerosis. With the score of 1, a range between 10 and 25. With level 2, a range between 25 and 50%. With the level 3, more than 50%, so an advanced and severe renal damage. This is very difficult also to read the table, just to understand all type of analysis we've performed in order to detect the relationship between the renal damage and the age, gender, comorbidities, the presence of hypertension, diabetes, the use of drugs such as diuretics, calcium channel blockers, beta blockers, RAS inhibitor, ACA inhibitors, and also using different estimated GFR formula. For example, the MDRD, the FAST NCQ, and the CKD-AP. And then we saw also the chronicity score, which was very surprising because the majority of our patients display a very low SETI score, suggesting that probably this kind of patient, even though with cancer, did not have severe chronic nephropathies, because the majority of these display a SETI score less than 2, so at the initial fibrosis level. And what we found in this box plot distribution, well, using different statistical analysis, is that there is a trend. So the renal modification, the renal histological modification, goes parallel to the CKD classification, suggesting that if you have a high renal damage score, so more than 2 or 3, you tend to have a chronic kidney disease stage 3 or 4. But this is only a trend, and sometimes you can have a very huge error. For example, if you see in these slides, we can say that some patient with 0 score, so without any type of renal damage in renal histology, has a CKD 3 stage for estimated GFR method. So if you go to score 1 using CKD-AP but also MDRD, you can see that without huge discrepancy with renal histologies, and so with very low grade of interstitial fibrosis and arterial damage, you have 22% that estimated GFR consider CKD 3 stage. So we are in a paradox, patient without renal damage but considered affected by renal diseases using an estimated GFR. And if you remember the beginning of my presentation, you can well consider that even though you have no urinary abnormalities, if your estimated GFR is less than 60, you are a CKD patient. But in this case, you are not a CKD patient because the renal atrophy and tubular damage are very less. If you consider that when you perform a renal transplant, 0, 1 or 2 are considered well and good for transplantation. On the other hand, if you go when you have an important renal damage, so higher than 3, you can see that about 20% of patients are CKD 1 or 2. So if they don't have urinary abnormalities, estimated GFR consider them normal renal function or with a mild reduction of renal function, but not CKD patient. That means that we have the opposite situation. So patients who have a real renal damage that are considered for estimated GFR classification, normal renal function or slightly decreased renal function. So we have the two sides of the coin, some normal patients that are considered chronic kidney disease and some affected patients that are considered normal. And this error is not negligible. That are the conclusion of our work that explain that probably there are a lot of mechanisms that should be more investigated, also because the accuracy and so the precision medicine in this patient failed totally. So if we consider a percentage less than 50%, that would be okay, but if we consider 20%, it means that 2 patients over 8 are considering a wrong CKD classification, and consider if they should undergo a chemotherapy or a surgical approach. It can affect very dramatically the lifespan of this patient to fail the correct CKD classification. And so there are other work in progress that my group are moving on and roll out, always on the renal histology and CKD classification. In these cases, we consider about 200 and 150 patients who underwent radical nephrectomy, and we investigated the relationship between renal histology and acute kidney injury onset and chronic kidney disease at 1 year. What we found was that this patient had a very huge decay in the first days after surgery, and so during the hospitalization, with the 50% of patients that experience radical nephrectomy that arrive in stage 1 AKI, so 50%, and 10% stage 2 AKI. And then the decrease of chronic kidney disease, and so the decrease of eGFR was very high also after 1 year. And what was very surprising was that especially normal renal function, so patients with a GFR higher than 60 experienced the usual decay, and the renal mechanism compensatory, so the hyperfiltration after 1 year failed to reproduce the baseline level, suggesting two important things. The first one is that maybe the normal renal function patient who have a renal nephrectomy at the age of 60, which is the medium age for nephrectomy patient for cancer, are unable to use the compensatory mechanism both in acute then after 1 year. But also another more intriguing idea that perhaps if you have only one kidney and you remove one at 60 years, even though you remain with 50 ml or 45 ml of eGFR, you are not a chronic kidney disease. You simply have one kidney that works well, but it is not able to hyperfiltrate. So new ideas that we should start thinking about. But the nephrology is always in the midst, as Esteban always remember me, because consider these cases. In these cases, we have guys with 75 years old, a normal BMI a little higher, with hypertension, diabetes, an estimated eGFR formula of 35 ml, and Chronicity Score or SETI 2. These guys underwent radical nephrectomy. So normally with 35 ml we consider that this guy will experience dialysis, because if with 2 kidney we have 35, without one maybe half. However, what happened? That after 3 years, so 36 months, these guys experience a decay of only 4 ml minutes. And it's quite interesting because it means that or probably at the beginning the estimated eGFR was not real, or at the end, because it's quite impossible that after 3 years removing a kidney, which was observed, and so there was the healthy part inside this kidney that was not all compromised, that removing one kidney you can lose only 4 ml. So there is something more, there is something beyond. And also these guys of 68 years old, obese, with a BMI of 33, hypertensive, with a starting point of 74 ml and a Chronicity Score or SETI of 2. What happened after 3 years? A very huge decay. So in this case, this guy experienced a decay of 58 ml, which is a very big amount of eGFR less. So these two cases are important to understand that apart from estimated eGFR and histology, we have a lot of things to do. And one idea is to create, together with the NBIBA group, a new NBIBA 2.0 in order to use not the estimated GFR, but the measured GFR using Yoxol plasma clearance together to the renal histology, in order to have a modern panel and I can say a kidney test in order to detect the real renal function of this patient. And so we arrive to the conclusion. These conclusions are not completely mine. Yes, I have to be honest. They are taken by Glassock, they are taken by Himmelfarb, Wieners, the very pillar and important nephrologists in the past. But I want to remember, because in my point of view, they are fundamental for each of us. The concept of generic chronic kidney disease has been the big idea in nephrology since 2002. Clinically, the KDIGO classification stages system provides clinicians a new effort, a new instrument to anticipate complication and to avoid patients to go to end-stage renal disease, but also to avoid and treat some complications, such as anemia, mineral and bone disorder. This transformation was warmly welcomed and widely adopted, as Glasgow repeats several times. All this was laudable, but the big idea has passed a tipping point. A lot of clinicians say estimated GFR is the correct method, and so stop. If you are chronic kidney disease first stage using estimated GFR, you are chronic kidney disease. In fact, the absence of reliable method to detect the presence of a real renal damage without performing renal histology, so renal biopsies, which is impossible to do in each patient, or a measured GFR, can create in a lot of cases misunderstanding. As we saw in our study, 50% of patients completely different, 20% of patients with CKD but not real CKD, and also the opposite. And so, in my point of view, what I think is that we should embrace the current classification system and move forward together to prepare further advances in our discipline. We should need new classification based on new instrument, because CKD classification are fundamental to avoid the confusion and also to create the awareness of chronic kidney disease in the general population, also because chronic kidney disease is quite asymptomatic. But on the other hand, we should use the right instrument to detect and to stratify patients in the correct chronic kidney disease classes.